Hello all, welcome to my show Chronicles of a Learner RN, and thank you for listening. My name's Ritika, I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today we'll be talking about a case I saw 4 to 5 months ago, young man with flu A that ended up needing intubation and eventually ECMO, and we'll discuss what ECMO is soon. As a disclaimer, I will not be providing any personalized information. All names, numbers, and results will be altered to protect the privacy of the patient this story is derived from. So, for context, this story centers around a young man who came in severe respiratory distress. We later found out he was flu A positive through a rapid swab. He was diagnosed with viral pneumonitis and subsequently was intubated. The rationale was that the illness progression was going to get worse before it got better. His work of breathing was severe, he was tripoding, speaking words, hypoxic. We considered BiPAP, but it was dismissed in favour of intubation because his beard it was huge. So we attempted high flow nasal prongs to support him while we shaved his huge beard for the intubation attempt. However, we had shaved his beard, so once that was done, we were like, why don't we just try BiPAP? So we did. But it only had a bit of a moderate effect, so ICU came down after about an hour and a half on BiPAP and decided to still intubate, thinking that it was going to get worse before it got better. I helped with the intubation. I took the role as airway nurse independently for the first time. Did have one of my educators with me just as a guiding presence. Before she had gotten there, I'd already laid everything out, everything I needed, and then she just went in and checked, and she was like, yeah, you've done great. Airway is actually pretty simple because I had time to set up and everything because they were umming and ahhing about intubation or not. Like, I had set up, but then they were like, no, we'll wait, we won't intubate. And then it was like 3 o'clock and they were like, actually, no, we will intubate, but I left all my stuff out. And then on the same note, all the drugs had already been drawn up, so everything was pretty smooth. We were like ready to go immediately. Obviously, he went to the ICU afterwards, and then through word of mouth, I found out that while in ICU, his left ventricle became dysfunctional. So dysfunctional that he required ECMO and was transferred to an ECMO ICU for ongoing management because we can't do it, let alone start it. Unfortunately, it's all external after that, so I don't really know what happened or how he's doing now, but I hope that he's, fully recovered and doing well with no lasting side effects. Before we get into the juicy stuff, I just want to preface by saying that flu A this year, 2025, has been way more prevalent than COVID, especially with how prevalent COVID has been over the last 5 years. People are presenting more often and more sick than ever before. It's recommended even by the Victorian government, I don't know about other governments, but the Victorian government, to prioritise getting the flu jab this year particularly. It won't really stop you from getting infected if you do get infected, but it will significantly reduce the severity. Not only will it protect you though, it'll protect those around you. So like at-risk populations, children, the elderly, immunocompromised. So getting your flu jab is worth it, especially this year. Although it may be a little late, considering everybody's already had the flu. So, yeah. So the pathophysiology of the flu, there isn't really much to discuss other than the fact that it's a virus. Antibiotics won't work. Usually just rest and hydration is adequate enough. That you just stay at home, you lie in bed, you die for a few days, but then you're fine. At-risk groups are like those populations I said before, children, the elderly, immunocompromised. They can get antivirals like Tamiflu, but most don't need it. However, viruses can lead to sepsis, all the same as bacterial infections. So, pneumonitis. What is pneumonitis? Well, it is not an infection. The definition is literally just inflammation of the airways, particularly the little air sacs, the alveoli. This inflammation can be caused by a multitude of things. allergens, chemicals, viruses, autoimmune diseases, quite a few more things, but I'm not going to list them all today. Symptoms are your usual basic respiratory symptoms: shortness of breath, chest discomfort, hypoxia, worker breathing, blah, 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 blah. So a common question I get though is, what is the difference between pneumonitis and pneumonia? So pneumonia, bacterial infection pneumonia, is a specific type of pneumonitis due to bacterial infection. That's why I said he was diagnosed with viral pneumonitis. Pneumonitis is an umbrella term for lung inflammation. Pneumonia is a bacterial infection that causes pneumonitis. But we don't call it pneumonitis because we are treating the infection primarily, and then the inflammation is sort of just tacked on there. But we're treating the infection, not the inflammation. This is evident on chest x-ray interpretations. Pneumonia is very easily identifiable. Usually there's a patch of what we call consolidation or white stuff on the x-ray that corresponds to where we might hear crackles, which leads to pneumonia. But pneumonitis, usually the chest x-ray is clear because obviously there's no fluid in the lung, it's just inflammation. So pneumonitis, the diagnosis of pneumonitis is based on clinical picture and bloods alone. So why is pneumonitis so dangerous? Well, basically it can lead to respiratory failure, is basically where the lungs can't exchange gas effectively, which leads to hypoxemia, not hypoxia. Hypoxemia is low oxygen concentration in the blood, and hypercapnia, which is high CO2 concentration in the blood. It can also lead to something called pulmonary hypertension. This is when the blood pressure in the arteries of the lungs is abnormally high, straining the right ventricles, which obviously supplies blood to the heart, to the lungs. Straining that right ventricle over time will eventually strain the left ventricle. You'll get both left-sided and right-sided heart failure. So we now know that pneumonitis is quite, a dangerous sort of condition. So how do we fix it? Well, usually we try less invasive measures like the high flow, like the BiPAP, but sometimes they just don't work. And in this case, we were thinking he was going to get worse before it gets better. So we sort of, instead of waiting until it gets worse, we sort of preemptively set him up to start healing earlier. This is why we intubate. But there are other reasons why we intubate for other different sort of conditions. If the patient's airway is at risk, so if they've got a low GCS from, say, drug overdose, they usually say GCS of 8 equals intubate or something like that. Basically, low GCS means that risk of airway occlusion is a lot higher. That being said, if the airway is obstructed or they've got severe work of breathing not able to be settled with, say, NIV or ongoing hypoxia despite current management, that would be an indication for intubation. How do we intubate? I've got so many questions today. Basically, to the procedure itself, we provide extreme oxygenation before the procedure. This will be done 2 ways. Actually, in this case, it was done through the BiPAP. So we kept the BiPAP on him until the very last second when it was time to intubate. But usually for like procedural sedation and other stuff, we'll put 2 methods of oxygenation on their face. We'll put nasal prongs and we'll put a Hudson mask. Hudson mask will be running at 10-15 liters in a minute, but the nasal prongs will also be running at 15 liters a minute. You may hear that people say no more than 4 liters a minute of oxygen should go through nasal prongs. This is the exception. Yet you twist the knob until it's hitting the top, and then you can twist it even more to get up to, I think, about 30 liters of oxygen flow. It's just that the little thing on top caps at 15 liters. This is because we want to facilitate something called apneic oxygenation. Basically, the rationale is that even once they stop initiating their own breaths, Just the sheer amount of oxygen going through the nasal prongs is enough to continue oxygenating the blood, at least for, I think, a few minutes, even while they're not breathing. So that's the reason we do that. We'll take off the Hudson mask, but we'll keep the nasal prongs on to facilitate this apneic oxygenation. This just gives us more time than we commonly would have to get the tube in once they're sedated and paralyzed. That being said, we sedate and paralyze and then insert the tube. Obviously, we'd want to do that. We don't want to do it on an awake person that can gag. Then once the tube is in, we connect them to the ventilator and begin ventilation. Sedation-wise, we usually use ketamine or propofol, one of the two. Ketamine is what we call an airway sparing drug. So it's basically how it's described. They don't lose their airway, like their tongue doesn't roll back to the back of their throat, and they don't need any draw thrust or anything to keep their airway open. Propofol is the exact opposite. Like when we sedate people for procedural sedation and we use propofol, usually we'll need some jaw thrust to keep their airway open and to keep them breathing, just because everything is so loose. But those are two agents we usually use for sedation, especially specifically in my work, but there's a lot of other things you can use like fentanyl and other pain relief. Paralysis wise though, we only usually use rocuronium. This is because it has a shorter onset time and a shorter half-life. It takes about 1 minute to fully kick in, so once it's gone in, we'll keep the oxygenation on and someone will keep time and we'll wait 1 minute. Once the 1 minute is up, we take off the oxygen and the timer begins for our first attempt. Someone that has got their eye on the monitor will be keeping an eye on the oxygen levels, and the airway doctor is usually told when it hits a certain mark. So say our threshold is 85%. Once it hits 85% on the monitor, someone will tell the airway doctor, it's hit 85%, you need to stop and resume bagging. If they haven't gotten the tube in by then, they take it out, we resume bagging, or like the jaw thrust and the BVM, and we move on to the second plan. Usually we have 4 plans. Plans A, B, C, D. First plan A is usually when the resus reg will have a go, always under the supervision of a consultant though. Plan B is maybe a different reg, or the consultant themselves, or the same reg with a different method. So if they're not using the video, the CMAC, then maybe using video guided laryngoscope. Yeah, that's the one. Plan C then could be using the consultant, and then plan D is usually what we call a KICO, or like Americans might call it a trach or something like that. So say we got it in. The tube we use is called an ETT, endotracheal tube. Goes down the airway, has a balloon at the end of it, which me as the airway nurse pumps up with a 10 ml syringe. This expands to the walls of the airway, stops air from leaking through, and stops it from moving, essentially, as well. This provides adequate airflow in and out through the tube, not around the tube. And then once we've cuffed up the tube, cuff up, whatever. There are a few things we do to confirm. Oh my God. There's a few things we do to confirm placement. We can auscultate, so we should be able to hear breath sounds bilaterally. Sometimes if you put it too far, because the right bronchus is higher than the left bronchus, so it tends to go into the right. If you put it in too far, you'll only hear breath sounds on the right. And then you can pull it up a little bit. Chest x-ray, we can get to definitively show placement. End-tidal CO2 will show the caliber of exhale and the amount of CO2 being exhaled. Usually in the community, we've got this color metric. I don't know if that's the right word. It goes, gold is good, purple is poop. I don't know. Basically, 6 breaths with the tube. If it goes gold, you've got CO2 and you're in the right spot. Obviously, in hospital, we have access to monitors, so we don't do this. But if, say, we had to tube in like the parking lot or something like that, then that is what we'd use. So once we've got the tube in, we'd bag for a little bit, just make sure it's in before connecting to the ventilator. So the primary settings that we put it on is called, there's a lot of letters coming up, it's called VCSIMV, or volume controlled synchronized intermittent mechanical ventilation. I think that's right. SIMV. Intermittent? Yeah, I think so. We'll just call it that. I'm sure that's right. So basically VC volume control, like it stands for, we control how much volume goes in and out of the lungs. If you listen to my last episode on asthma, you'd remember that in NIV or BiPAP, that is the one measurement we cannot control, or two measurements, one of two. We cannot control the rest rate and we cannot control the tidal volume. We cannot control how much goes in or out on NIV because the patient is facilitating that with their own intrinsic breaths. However, with mechanical ventilation, we are doing that for them. So basically we get an estimated weight based off of height, and there's like this little chart that tells us what the adequate tidal volume should be for height and weight. And that's how we figure it out. And then the SIMV bit is basically saying that if the patient takes their own breath, so their body intrinsically initiates a breath, the machine will support that breath through similar NIV settings like pressure support and PEEP. But otherwise, if the patient does not instigate or initiate their own breath, then in like a specific amount of time, then the machine will deliver that breath to them. This is primarily used because it reduces respiratory muscle atrophy. So if they don't actively use their lungs, they can, weaken. That's a good way to put it. And then again, a difference between mechanical ventilation and NIV is that we control pretty much everything. With NIV, we can control FiO2, pressure support, and PEEP. In mechanical ventilation, we can control rest rate, we can control tidal volume or how much goes in. We can also control FiO2, and we can control pressure support and PEEP. There's other stuff we can tinker with, what's called the inspiratory to expiratory ratio. So basically we can tell the machine how long to do the inspiratory breath, how long to do the expiratory. So we can change the time to say 2 second inspiratory time, 4 seconds expiratory time. So the machine will push air in for 2 seconds and then take 4 seconds to get everything out. In vice versa, we can do it the other way around. Long expiratory time, short expiratory time. The reason we do these is because if we want to get rid of CO2, we'd prolong the expiratory time, try and blow off more of it, and then short inspiratory time to get less tidal volume in, get more of that CO2 out. If the CO2 is low, then we'd do it the other way around. Big breath in, small breath out, to reduce the amount of CO2 that's getting exhaled. Once the tube's in though, we need to sort out ongoing sedation because obviously we can't keep them awake because that'd be very uncomfortable. So we want ongoing sedation, but we don't want ongoing paralysis because that counteracts the SIMV bit because we want them to eventually, once the paralysis wears off, to take some of their own breaths. So ongoing sedation, usually we use fentanyl and propofol. Because fentanyl, obviously, it's uncomfortable and it could be painful. So we use fentanyl for pain management and then propofol primarily to keep them asleep. We had a case, I didn't have a case, one of the night shift nurses when I came on in the morning. They're about to take someone to ICU and they told us a story that he had been intubated because of I think it was a polypharmacy overdose. He was really young. But he'd done this multiple times before and he'd been intubated multiple times before. And because of that, I think he was a little bit tolerant to like the propofol and stuff because the nurses, she was asking other nurses, hey, you good? And she was like, the patient opened his eyes and nodded with like the tube in and they were like, hey, we gotta got to up the sedation. So yes, sedation is very important because we need to keep them asleep. Asleep but not paralyzed. Once an intubation or an ET tube is in, we'll also need to, it doesn't need to be immediately, but we'll also need to put in an NG tube. This is needed to decompress the stomach with the increase of ferocity of airflow. Same thing with pediatrics on high flow nasal prongs. Similar concept. They've got all this air getting pushed into their lungs, essentially pushed into their stomach. And if we don't decompress that, they'll get bloated and bloated and bloated until, well, they won't feel very nice. I can say that. Then we need ongoing monitoring as well, because obviously they're now unconscious and we are breathing for them. Usually that comes with some hemodynamic compromise. Not always, but most of the time if you're sedated and you're like septic or something and it's not just for like a day or two, you might get an art line for invasive BP monitoring. You'll also get an IDC, because now that they're asleep, they cannot control their bladder or their bowels. And obviously you need the end tidal, which I'll talk about in 2 seconds. You need your SpO2 monitoring, your SATs monitoring. You can adjust your FiO2 as necessary to keep your SpO2 target. And obviously we start on 100% FiO2, but you want to turn it down to the lowest possible number to maintain your adequate target. On our oxylogs, the lowest they go to is 40%. So even then, we can't take it all the way down to room air. Like they'll still get some oxygen. And then end tidal. Basically, I remember talking about this with my educator in a lot of detail. But basically, end tidal shows you exhalation. When you breathe out, this little waveform goes up into a square and it comes down when you breathe in. When we go up and it hits the end of that top, if you think about a little rectangle, go from the bottom to the top over, that bit over on the right hand side is called your end tidal CO2. And this is the number that's calculated. So like our PCO2 from our BBG, the numbers we want are 35 to 45. Obviously, when we've got procedural sedation and stuff and people are just breathing like they normally do, you're not actually getting 35 to 45 because, well, people's respirations are irregular. They'll breathe in hard, then they'll breathe in soft, then they'll take a big breath in. Some people might even stop breathing for a couple of seconds, or they get so shallow that the nasal prongs can't pick them up. Many different things. But when we attach it to the ventilator, you're going to get a good reading pretty much all the time. So CO2 can be monitored through that as well as through the blood tests. Different waveforms mean different things. So if you're seeing like a really common one to look out for, particularly when trying to confirm placement using ET, if you've got a waveform that sort of just drowns out in the little thingies, what are they called? Oh, I can't remember. Little waveforms just keep getting smaller and smaller until you see nothing. That is very, very indicative of an esophageal intubation. Basically, you've gone into the esophagus and the last of that CO2 is getting taken out until you're not ventilating anything. That is very alarming. You should take it out immediately. Start pagging and try again. If you've done a right-sided intubation, I think, I can't remember the waveform off by heart by now. I can't remember the waveform off by heart, but it looks weird. And especially there's something called a sawtooth waveform. If you've got asthma and you can get breath in, but you can't get breath out appropriately, then that would cause it to be a sawtooth. So different waveforms mean different things. What you're looking for is a square though, and your numbers between 35 and 45. That being said, you titrate your ventilator settings to ETCO2 and your VBG/ABG, whichever one you use. You correlate the two numbers and then you basically titrate based off that. So say the SATs are low, so in the 90, and you're aiming for above 95. but then you take an ABG, and for the FiO2 that you're at, your O2 is within normal levels, you'd make the executive decision to just leave the FiO2 for the moment. Or maybe what you can do is increase PEEP or something like that. Just not blindly increasing FiO2. Stuff like that. And like CO2, you want to correlate your PCO2 to your ETCO2. If there's, say, like a machine issue or something like that, and you're getting odd numbers based on the blood results, then you could adjust some stuff, see how that goes. There are specific settings you change based on what the issue is. So the way we learnt it, if it's a CO2 issue, you adjust the rest rate and the tidal volume. This will help to either blow off or not blow off CO2. If it's an oxygenation issue, you adjust PEEP and FiO2. As we discussed last episode, PEEP is how much we keep the lungs open more than usual when the breath ends. If we think about that balloon, I'm just assuming that you've listened to my last episode, but if you haven't, I heard from this TikToker, Nurse Gwenny, that this very same issue, if you're dealing with an oxygenation issue, instead of just blindly increasing the FiO2 and then you're not seeing an increase in the SpO2, increasing PEEP will be your saving grace. This is because if you think about a balloon, that first breath into the balloon is extremely hard, but once it expands a little bit, it becomes much easier. This is the function of PEEP. If we didn't have PEEP, our alveoli will shrink down to the size of that not blown up balloon, and the body will need to exert a lot of effort, just like we need to exert a lot of effort to open it. That being said, if we increase PEEP, so we increase how big the alveoli are at the end of a breath, this will decrease the thickness of the membrane, allowing for better gas exchange. The way she showed us was that if she blew up the balloon bigger and left it like that, the dangly unfilled balloon, you couldn't see the light of a torch through it. But the bigger she made the balloon, the more light you could see. Same thing with gas exchange and diffusion. Now, I realize we're running out of time, but I'm almost finished. Guys. Just hang on. It won't be as long as my mini-sode on arrhythmias, I promise. We'll just quickly go through a primary assessment. This is based on not Flu Man, but another intubated patient I looked after recently for the first time, like by myself, although with an educator, and then she basically just made sure I was doing okay while I was the main nurse for the patient. So we did it head to toe together. Sorry guys, I just ate food. So we start with airway, your ABCDE airway. You put in your ETT size, so say like a 8.0, and how high it is, like up to the lips or up to the teeth. Usually in documentation it'll say what it's supposed to be. So say like 24 centimeters at the lips. Then you check that, and if it's say 50 centimeters at the lips, then you'd write that down, and then you'd get the doctor in to come and have a look because it's probably dislodged. But then this would be correlated by low SpO2, lack of breath sounds, blah, 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 which we're going to get into. Then you get to your breathing. You will put in your ventilator settings, your ventilator measurements. Those are two different things. Settings are what you put into the machine. Measurements are what is actually happening. So you could set the tidal volume to 500 mils per breath based on their height and weight. But if something's wrong, say the patient is agitated, they're biting the tube, or there's some sort of obstruction, there's like mucus or secretions in the tube and all that air is not able to get in, and say you're reaching too much pressure, like we talked about last week, there's something called a PIP, peak inspiratory pressure. This is usually 30 centimeters of water. The ventilator will cap any breath, if it hits above, I'm talking about our oxylog, I don't know about other ventilators, but ours caps off at 5 centimeters of water below what we set. So we usually keep the P max, is what we call it on the ventilator, at 30 centimeters of water. The machine itself will stop a breath at 25. So if it's consistently hitting this 25 centimeters of water, it'll start alarming, I think it's pressure high, then your tidal volumes will decrease. That is what I mean by measurements, because if it's doing this, you want to record how much is actually going in, because this is, if you remember from last week, we talked about dead space in the lungs. Yeah, dead space. Dead space? Yeah, I think it was dead space. I can't remember now. Where 150 mils is not used in gas exchange. This is very important because if you're not reaching your tidal volume, they could be getting less air than they are supposed to. Then you want to check your breath sounds. You want to auscultate, usually the anterior chest. Make sure you can hear breath sounds on both sides, where they're equal, what you can hear, if you can hear crackles, wheezes, upper airway noises like secretion, stuff like that. You'll write down what your SpO2 is. You'll write down what your EtCO2 is on the monitor. Then we move to circulation. You do your heart rate, BP. If you're doing outline and vasopressors, then describe where the outline is, what vasopressors you're on, what it was before, what it is now, stuff like that. Whether they've got edema and central cap refill. Your disability, your GCS, it should be 3 because they should be heavily sedated. If it's not 3, then I would be worried, to be honest. Now, you can't really ask them if they've got pain, but you definitely can tell if they're distressed. So if you're seeing tears, if you're seeing clenched jaw and they're biting on the tube, if their heart rate and their BP is elevated, those are all signs of distress and you should probably increase your sedation. And then in your exposure, you'd be doing your temperature, you'd be listing all your lines. So your IDC, your outline, your cannulas, your NGT, all the good stuff. That's pretty much your primary assessment. And then you'd go in and you'd do a head to toe. Obviously, you wouldn't repeat yourself for stuff like respiratory and cardiovascular and CNS and stuff like that. So we'll go back to flu man. Let's talk about complications of the flu. To be honest, I wasn't actually too sure why this man ended up having left ventricular dysfunction. So all this open disclosure, I Googled it. Basically, the inflammation of the lungs can get so bad that it can spread to the heart, causing myocardial injury. This links in with the pulmonary hypertension I mentioned before and its effect on hypoxia. Increasing afterload, or basically the BP of the pulmonary arteries, so afterload is how much force the right ventricle or left ventricle has to push against to get the blood out. So increasing the force needed will strain the right ventricle because the right ventricle goes into the lungs. However, there's something called ventricular interdependence. They basically need to work with each other. That means if your right ventricle is straining, after a while your left ventricle will strain too. Another sort of theory I have is a bad ventilation VQ mismatch. So don't ask me what the Q stands for, but VQ stands for ventilation perfusion ratio. So obviously the V stands for ventilation, but I don't know what the Q comes from. It's probably some other language or something. But basically this is how the lungs deal with ventilation or perfusion issues. So ventilation issues include like fluid in the alveoli from pneumonia or bronchoconstriction. Basically, it's an issue with oxygenation, which lowers the V value of the VQ, lowering the VQ ratio. This leads to a phenomenon called shunting, which is where blood flow bypasses gas exchange with the affected alveoli, meaning the blood still runs past the alveoli, but there's no gas exchange. This equals basically low oxygenation. And then perfusion issue, like pulmonary embolisms, sometimes COPD can be a perfusion issue. This is an issue with gas exchange into the capillaries. So you've got a low Q value equals a high VQ ratio. Basic maths, if you lower the denominator, your ratio gets bigger. This leads to what's called dead space. Again, similar to the anatomical dead space. That's what it's called, anatomical dead space. This is a different kind of dead space. In the alveoli, you will have gas in there ready to get exchanged and diffused into the capillaries. But if there's no blood flow to those capillaries, the gas doesn't get exchanged. So this is what's called dead space. Yeah, ventilation. Basically, there is no ventilation. This will lead to primarily a high CO2. So in his case, it'd be a ventilation issue. Because of the inflammation, you'd have trouble getting oxygen into the alveoli. Therefore, blood that's running through the capillaries will just not get oxygenated. And then the other reason is probably sepsis. Well, it could be all three of them, to be honest. I really don't know. If I see him again, I'll find out though. So let's finally talk about ECMO. And I did say we'd be almost finished, but now I really promise we'll be almost finished. So ECMO stands for extracorporeal membrane oxygenation. Basically, it acts as a bypass for the heart and lungs or just the lungs, depending on whether they need lung support or lung and heart support. So it works by these very smart accredited ECMO doctors putting two huge cannula or tubes usually in the only time I've seen it done is they put it in both the left and the right femoral artery and vein, or vein and vein. But sometimes one will get put in the femoral artery or vein, the other one will get put in the carotid. Yeah, the carotid. I think that one's right. It can get put in any very, very large artery or vein. But the one I saw was just femoral. These tubes, one tube will take out blood, or because it's a cannula, it'll just flush out. They send it through an external circuit that removes CO2 and oxygenates it, and then sends it back to the body. So there are two, like I just said, there are two types. You got venous-venous or venous-arterial. Venous-venous circuits are used for people with compromised lungs, where oxygenated blood is returned to the venous system and is able to be circulated by the heart adequately. This essentially relieves the lungs of oxygenation duty, allowing for lower ventilator settings and less risk of barotrauma. So basically what that means is, say flu man, I don't know if this is what happened or not, but flu man, he's on the intubation. We're at the highest settings we could do, and his oxygenation is just not getting better. His PEEP is already sky high. His FiO2 is sky high. It's already on 100%, and we just can't solve it. What they will do is they'll pop him on venous-venous ECMO. This will allow them to turn down the PEEP, turn down the FiO2, because now this external circuit is oxygenating the blood for him, and the lungs don't have to do that. Also, pushing lots of air in at high pressures will just keep expanding the lungs and can cause barotrauma, which in the long term is not good. And then venous arterial circuits are used to bypass the heart as well. This gives the heart a break and makes sure the body is well perfused and oxygenated without the heart actually needing to do it. This is usually done in cases of cardiogenic shock, which we discussed in sepsis part 2, which is basically when the left ventricle stops working efficiently. So I'm not too sure, I know he had left ventricular dysfunction, which is why he was put on ECMO, but I'm not sure whether they just wanted to oxygenate his blood, or basically whether they wanted to just help the lungs heal, or whether they needed to help the lungs and the heart heal. So I just wanted to preface again, just before we get into my next story, that I do not know how Flu Man ended up. I just know in our ICU, how he ended up, what we did about it, and then we sent him on his way. I actually found out from a patient I looked after maybe 2-3 days after, who was like a teacher or something at his school. And she was like, oh yeah, I knew a guy, he also had flu A and he came in and he was intubated. And I was like, oh my God. I didn't tell her, but I was like, damn, I know who you're talking about. But so yeah, I think it was going around. But yeah, I don't know what happened. The reason we put people on ECMO and very specific people that meet very specific criteria is because, one, it's very difficult to put them on ECMO. It puts a lot of risk onto the patient, risk of bleeding, risk of clots, risk of strokes, risk of PE, the lot. But the reason we do it is because it essentially bides time. It gives us leeway to figure out what's going on and how to fix it without expending unnecessary energy on, say, CPR or mechanical ventilation, especially when it's not working. So my last story of the day, and I promise it's like maybe 200 words, and then I'm finally done. Thank you guys for sticking along. Sticking along? Listening along. I don't know. It's really late, guys. And when I say really late, it's like 9:30. But that's late for me. I should be in bed. But here I am, telling you about ECMO Man. So we just heard about Flu Man. Last week we had Asthma Man. Today we have ECMO Man. This man was found unconscious and hypothermic in a running cold shower in like a hotel. He was last seen well the night before, and throughout the like hotel room that he was found in, there was like drug paraphernalia everywhere. So he probably had overdosed. Good guess. AV started CPR on site. I think they got ROSC at one point, but I'm not too sure. But he ended up arresting again, or he just stayed arrested. He came in on the Lucas machine, which is that really terrifying machine that you place on the chest and it does the chest compressions for you. And obviously I was there that day, but I was in the monitors. My friend was having a resus day before we started our postgrad in resus, and he stayed to help. So I got most of this information from him. But basically they went through the ALS algorithm and attempted to warm him up as fast as possible, because the consultant said people aren't dead until they're warm and dead. So if they're hypothermic, you need to continue efforts until they are, well, of normal temperature. Luckily for them, luckily for us, and this is very rare, they probably would have just continued had the ECMO consultant not been there, but the ECMO consultant was actually at Maroondah that day in the ICU by some miracle, and they were able to come down quite quickly, assess, and call the ECMO crew to come. I think the ECMO crew, I think they come from the Alfred, but I'm not too sure, but like this crew showed up with like tennis bags or hockey bags just full of equipment, like the tubes and the circuit itself. So they all scrubbed in and they got the ECMO going. So in this case, it was venous arterial ECMO. This was to basically, once again, bypass the heart. So my friend said once the VA ECMO had started, they were able to stop compressions because this machine is now oxygenating the blood for them. They don't need to continue pushing and it's going through the arterial system, which means it's perfusing into the tissue, meaning they don't need to manually pump the heart anymore. Once the ECMO was in, this, mind you, this is lasting a few hours. This has lasted from 12 o'clock to 6 o'clock. It was a very long effort. The specialist ARV team, in conjunction with the ECMO team, took him, I think it was the Alfred, but I'm not really too sure. I don't know who does ECMO. And then I think, mind you, this was a long time ago, like more than 6 months ago. So I'm working off of pure memory here. But I think it was the next day that we found out that he had passed away. The family had decided to turn off the ECMO, which was pretty sad to hear. But I think, and this is just speculation, because obviously I personally did not look after this patient. I just helped bring them stuff while I was in the monitors. But I heard that AV had thought that rigor mortis had already begun by the time ECMO was in, and he was already on his way out due to his discolored and stiff leg. but we're not too sure. It quite literally is just speculation. I don't know. It could just be that his limb was cold. Another complication of ECMO is lower limb ischemia. So obviously you're going at the femorals. You can lose blood circulation to the legs. So that could be what has happened, but we never know. So today, just a little recap with the 1 minute I've got left. We talked about flu A, why it's severe this year, why you should get your flu jab. We talked about Flu Man, what happened, how we tubed him, how he went. We talked about pneumonitis versus pneumonia, because if anybody asks, now you know. We talked about intubation in general. We talked about ventilator settings we commonly use, what needs to be done after they're intubated, how we do a primary assessment, what could have been the cause of his deterioration after he was already intubated. And then we discussed ECMO, extracorporeal membrane oxygenation, how we can bypass the lungs, how we can bypass the heart and the lungs and give the body the break it deserves when it's very, very sick. And then we talked about ECMO Man, who sadly did not survive. I feel like that's a running theme in my podcast, which is really unfortunate. I should really think of a story where somebody survives and thrives and doesn't die. This wraps up this episode of my show Chronicles of a Loner RN. I certainly have learnt a lot today, and I hope you have too. I have a plethora of cases and learning experiences I am excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.